Thank you very much. Yeah, go ahead.
Thanks so much. That was absolutely fantastic. And I think that this kind of data and the use of pooling these kinds of collected data are really what we're going to need to be very careful about being forward-thinking about, because this is where we're going, and we want this report to be able to address things moving forward. So I have a question to ask you to reflect a little bit on. You did a beautiful job of outlining the strengths and the weaknesses. Then I was interested in your presentation of the antibiotic paper. You mentioned the findings and then also mentioned the limitations for things like housing and other reported measures, and which can have huge impacts. So I'm wondering, if you were looking at this study, for example, your study FRESH, what would be, and you were looking at a framework for things about sort of thinking about how strongly do you believe it? And I know this is tough to ask you to do, but what kinds of data elements would you want a framework to highlight for you in terms of helping you understand the strengths of a study, which, for example, the measures of SES were insurance payer information. The race data were by the vendor report. You don't have information on income, housing, crowding, all these things that can lead to both weight status, neighborhood geography, built environment stuff. So I'm just wondering if you could think about what would we need to put in a framework to help us understand these kinds of studies?
Yeah, I think that's a great way to think about things. And the conclusion that we're coming to, the more we delve into this, is we have to really think about obesity, which is such a multifactorial disorder, in terms of an archipelago of frameworks. Right? What a EHR-based framework can bring to you is good measurement of anthropometrics, is detailed data about medication exposures, but it has huge gaps in the environmental and socioeconomic factors. What school data can bring to you is information about community and school participation, and if you're really lucky, maybe school-related physical activities. But it has huge gaps around comorbidities and around healthcare-related data. What census data bring to you is some information about demographics. What nobody brings to you at this point is information about genetics. I think it's unlikely that we're going to find a framework that is going to incorporate all of these kinds of data, and so part of where I think we need to focus is on our ability to link information across these islands so that we can get a better both population level and, as we get better able to address the privacy related and policy related issues, individual longitudinal level view of what's actually going on in all of these different spheres of a person's life.
Thank you, Charles, for that presentation. It was pretty striking when you showed your results using just an enormous N of more than 800,000 unique patients from birth to 18, that when you plotted your prevalence of obesity, it was really very consistent with N. Haynes, which is pretty fascinating, actually. I guess my question to you, when we think about EHR, we think about the promise of EHR. We think that there is a great opportunity to gather a large sample size, and we can ask some questions, but not all questions. Do you think that we could ask the questions of surveillance using EHR?
I do. And I think, in my view, things like EHRs and national surveys are nicely complementary techniques, right? Because you need a gold standard to know where gold is, right? And you need sort of careful stratification. I think we were mostly reflective of the population, but there's a little bit of luck that we were reflective of the population. So I think they don't replace careful surveys, but the things that EHRs and related systems bring for surveillance are numbers, longitudinality, the ability to subset data, and really rapid turnaround, right? So that 800,000 patients was over 2 years, right? At the moment, in the current 8 PedsNet sites, we have data on about 4.5 million kids, And I'm trying to remember the numbers we ran last week, but over 1 million of them were seen in the last year. So we have the ability to pivot quickly to detect changes. So essentially, we make up for the fact that each measurement is not quite as well regulated by the fact that there are hundreds of thousands of them, and on average, people are pretty good.
Right.
And we then have the ability to aggregate that data and respond to changes much more quickly. So I think it's a great tool for surveillance.
Right. And my follow-up question to that is the caveat that was mentioned earlier was this notion of the user versus the non-user. Mm-hmm. So we're only capturing those people that are going to the doctor.
Yes.
And the concern is that we know that higher risk populations don't get to the doctor. They don't have the same access. So how should we be cautious about those findings, given on the one hand, you just showed us some really powerful data that was very much in line with NHANES, and yet we know that there will be a non-user phenomena?
I think we need to be very careful about a number of things, right? Certainly we need to be very careful about comparing the demographics of the population we see to the overall demographics of the region. We also need, when we're dealing specifically with this kind of utilization data, to be careful not just about the people who are non-users, but who are users outside our catchment. Right? I'll take the Philadelphia example, for instance. There are 3 children's health systems in the catchment area, and so there are a bunch of users whom we won't see because they use other systems. Again, this comes back to the linkage question, right? Because the reality is most people take their kids to the doctor, right? Most people see a physician somewhere, right? And that results in good data. And part of what we're advocating in the learning health system model, just to pick a word at an IOM meeting, is the notion that we're collecting this data on representative populations. We should use it, right? The last thing that I want to mention in that vein is electronic health data is opening lots of new, very valuable possibilities. I don't want to lose the fact that in particular the underrepresented groups are likely not so much to be the people who never see a doctor, but the people who see small individual practices, right? Because they're kind of off the grid from an electronic health data perspective.
Thank you.
So I guess I was under the impression that electronic health records include most of the people who are patients. They have illness or diseases. Is that true or is not true?
So it depends a bit on which health system you're talking to. For all of these health systems, they include all of the patients. So they include both the sick patients and the well patients. Again, there's a little bit of a pediatric bias there because most well children will continue to see a physician every couple of years for well child checks, and so we have decent capture of healthy individuals in addition to sick.
Okay, so I actually was very interested in electronic health records. So I was getting a data set of about 16,000 from the electronic health records. And it turns out that most of the BMI data were not included in the records. I know you have a very complete BMI data. So how do you make sure that the physicians or the healthcare professional actually enter the data? And in your case, do you have to have a kind of a requirement from hospital CEOs say that we have to enter it's a requirement to enter the BMI data?
So we all, these hospitals all do have policies that say that, but I think we get 3 strong boosts. First of all, pediatricians want to know about growth, and if they enter the data, it lands in a growth chart and things like that, right? Second, I need at least the weight data to take care of kids because I can't dose medications without them. And third, the schools help us here, right? Because not just at the policy level where meaningful use is saying if you want to attest and get your CMS dollars, you have to show that you're measuring BMI, but the school that says in order to enroll in first grade, third grade, eighth grade, you have to bring me a piece of paper with your BMI on it, really acts as a driving factor for recording these data, because then there's actually a reward to the clinician. They're not just writing it down for somebody else.
Thank you.
Sure.
I had a question about how you identify unique individuals in the databases. So in particular, I can think of a situation in which a child sees in a private practice for primary care because you can get appointments, but maybe goes to a specialist at an academic medical center. Is it possible when you're dealing with across different networks to uniquely identify children?
So it's possible, yes. We're not very good at it, and that's one of the things that I think we're just approaching. Two issues there. One is there's no standard way to do that, right? There are methods that let you encrypt identifiers and then compare the encrypted values, but there isn't an accepted standard. And so for any two sites, the chance that you're using the same method is pretty low. The second is that the regulatory environment now, and really in many ways the kind of public environment as well, is skewed very, very strongly in favor of privacy, right? And both overweights, and I mean that in a statistical sense, not a value judgment, overweights the likelihood and the consequences of some piece of health-related information becoming public. And so that means that people are very reluctant to link data, just because you never quite know where your data goes.
Yeah, okay, thanks.
Okay, one last question, then we have to move on.
Thank you very much for your presentation. Now, just thinking along the lines of developing a framework. So if results were to be published based on these data.
Can you stand closer, Jackson?
If results were to be published based on these data, and we wanted to provide, potentially some guidance for people at the local level. It sounds like what you're saying is, it's important to think about the representativeness of the data. But then you also mentioned that, one of the gaps in these data is that there are no environmental and social variables that capture social and environmental factors. So what are your suggestions in terms of being able to assess the extent to which the participants in the study actually compare to the general population where your participants are coming from, particularly since you also mentioned that there are some users who may not be using your network. So how do we assess the representativeness? Because I guess helping us with the interpretation, like who is represented by these data?
Sure. There are a couple of different levels that we've at least thought about, and I'm sure there are a bunch that we could learn from other folks. I mean, there's the lowest level, which is look to the places where there are good generally available data, and that's mostly demographics based on census data. These hospitals are in urban areas, so we get a bit more of a boost from things like local public health departments, which can report on some of the relevant environmental exposures. But we're not, we have next to no data on things like parental occupation, right? You may get median income for a census tract, but no information on occupation. Or, you may get amount of green space within a half a mile from geocoding, but you don't get any family level information about amount of activity, that sort of thing. Part of what we'd like to do is encourage more linkage because that gives you a broader picture. Part of what we want to do is engage directly with the patients. Right, so what I didn't talk about here is this is observational work from the data that were collected just to do your well child check or treat your ear infection. Right? But there's the 30 minutes you're sitting in the waiting room waiting to get that health care delivered. And so one of the options is what are the ways that we can ask you to spend some of what would otherwise be downtime for you helping us to understand some of those environmental factors. So sort of directed data capture at the point of care, because we're already going to get good anthropometrics now. So maybe this is the right time to ask you about some of these other environmental factors.
Thank you so much, Dr. Bailey. It's a lot to digest. Thank you.